is Use of RAM Cannula for Low Birth Weight Infants by Dr. Rangasamy Ramanathan. Dr. Ramanathan is Professor of Pediatrics and Division Chief of Neonatology and Director of NICU at LAC and USC Medical Centers, Kirk School of Medicine, University of Southern California. Dr. Ramanathan also directs one of the largest fellowship programs in neonatal perinatal medicine in the US. And Dr. Ramanathan's research interests are surfactant therapy, non-invasive ventilation, and oxygen toxicity. Dr. Ramanathan has received many teaching awards, including David N. Shaw Physician of the Year Award and Lifetime Achievement Award from NAV, to name a few. Ramanathan also designed a nasal interface, which is called RAM Nasal Cannula, that is used to deliver non-invasive ventilations in many NICUs, including ours. Today, Dr. Ramanathan is going to talk on his invention, that is use of RAM cannula in low birth weight infants. Please welcome Dr. Ramanathan.
Good morning, everybody. Hope you can hear me, both here and on the virtual. I'd like to thank Dr. Sham for inviting me and the scientific committee and Lillian from NHM. I'm delighted to be here today to share some of the things. So I have a patent, joint patent with Neotech products. And if I receive any honorarium, I donate all of them to charity to help mothers, newborns, and children globally. Most of my charity work I do through Academia Pediatrics and AAP. Okay, so there are a number, after all these days, one of the most common things we do in the NICU or in the delivery room is providing positive pressure support, right? This is a more recent publication in 2020 from Melbourne, where they looked at interfaces for neonatal resuscitation, the systematic review, 5 randomized controlled trials, 1,225 patients. They looked at Leerdal, Fisher-Paykel, Resuscitate, Armstrong, Randall, Ohio, Mask, and the conclusion, there is little high-quality evidence for choosing an interface to provide positive pressure ventilation. Binasal cannula appears to offer advantages over face mask, but need further testing. Okay, that's in 2020. So again, what we do both in the delivery room or in the NICU is face mask to provide positive pressure support, or Argyle prongs or Hudson prongs, Inca, Neotech RAM nasal cannula, or nasal mask. So we have lots of issues with this bag and mask or other interfaces. So we designed the RAM nasal cannula. What is it? It is nothing but a simple binasal prongs interface designed like a nasal cannula with a standard 15 millimeter adapter. You can use it during neonatal resuscitation in the delivery room to provide Cpap or sustained inflation or NIPPV with the TVs. In the NICU, we use it to deliver CPAP, NIPPV, or all modes of non-invasive ventilation, including nasal high-frequency ventilation. Now, NIV NAVA, neurally adjusted ventilator assist, nasal oscillation or jet ventilation more recently, and we recommend using it for low-flow nasal cannula because the pressure delivered is high if you're using high flow rates with a RAM nasal cannula. And you can't measure it and you can't control it. That's the reason I don't like to use high-flow nasal cannula in preterm population. In the PICU patients, they use it a lot. And then there are some centers in the US, they even send babies home on a home ventilator, either from the PICU or the NICU with a RAM cannula. So why RAM cannula for resuscitation? This is a nice study from George Monson from Canada. They looked at using a respiratory function monitor. When you do bag and mask ventilation, how often airway obstruction happens or mask leak happens. Using a face mask during resuscitation results in airway obstruction. They defined a 75% decrease in the exhale tidal volume and happened in 26% of the time. That's 1 out of 4 babies. There's airway obstruction. When you use a mask, the tongue falls backward, you're going to obstruct the hypopharynx. Leaks is extremely common. 51% of the time, the mask leak and airway obstruction are very common, especially in very low birth weight infants with face mask. So the other interesting paper that came out of Netherlands in 2019 is that when they started using face mask in 429 preterm babies, all of them are less than or equal to 32 weeks. You can see that when you apply a face mask, the trigeminal cardiac reflux or TCR has been described many years ago, but nobody paid attention to that. In the newborn period, this authors did this. So what they found when you start providing positive pressure with a face mask, we actually trigger trigeminal cardiac reflux or TCR. What does it do? It results in bradycardia and desaturations. So they concluded that whether avoiding the sensitive area around the mouth by using alternative interfaces like nasal prongs would decrease the risk for inducing this trigeminal cardiac reflux and bradycardia. So here, Dr. Satyam was kind enough to draw this figure for me to explain that. So when you apply, what are the advantages of RAM cannula? One is less dead space. So whatever you apply, the gas going through the nasopharynx, you're completely eliminating oropharynx. So with the nasopharyngeal, you transmit all the gas into the nasopharynx. Are you okay? Seems to be very concerned there. Is it okay? Okay, the videos are not going to get, otherwise I'll just
We cannot project the slide online. What is your number? What is your number? Yeah. What is your number?
Okay, just have to close the power supply. Thank you. Okay, so very quickly, I'm going to, you can take a coffee break. So I was talking about the nasal interfaces that we use in the delivery room. There are a number of interfaces we use. Basically, the study they concluded that there is little high quality evidence to choose a particular nasal interface. Binasal cannula appears to offer some advantages, however, it needs further testing. Again, these are all the things that you're familiar with, many of you. In our unit, about more than 10 years ago, we designed the nasal cannula called the RAM nasal cannula. It's basically a simple binasal interface. As a standard 15-minute adapter, you can attach to any ventilator, or a bag, or TPs, or Neonatal to deliver all modes of ventilation, non-invasive ventilation, in the delivery room, or in the NICU, or in the PQ. Some centers, they even send babies home on a home ventilator. So again, why do we use RAM cannula for resuscitation? Because there are problems with airway obstruction and mask leak, especially in very low birth weight infants. Up to 50% of the time, it fails. And then more recently, they also described from Netherlands in this study of 430 babies. They looked at what is known as trigeminal cardiac reflux, or TCR. When you activate the trigeminal branches, you cause apnea 54% of the time. When you put the mask on, baby becomes apneic, and bradycardia and desaturations. The advantages of RAM cannula are, one, you are avoiding the oropharynx, big dead space. Whatever gas you're putting into the baby goes through the nasopharynx and then into the hypopharynx. And tongue, you're not pushing the tongue backwards. And more importantly, you have less chance for the trigeminal cardiac reflux, less chance for leaks compared to a mask resuscitation. So these are some of the potential advantages of using the RAM cannula in the DR. Nasal injuries also extremely common. This is a study from Ohio, where every single day when the babies are on the prongs, or organ prongs, they had an ENT fellow or doctor come and check the baby's nose, and they classified into different degrees of nasal injury, and they reported 13.2% with the binasal prongs. And you can see this is normal pink mucosa, little bit of ulceration. This is the granulation tissue, and here almost 50% of the passage is blocked. And then columnar necrosis. I was really surprised. This baby had 10 days of nasal Cpap use. You can see the beginning of the columnar necrosis, and then within 12 days, up to 2 more days, the columnar completely collapsed. And obviously, this baby needed a reconstructive surgery. So they reported 5.5% incidence of columnar necrosis. And again, another study from Switzerland in 2010, they report nasal injuries with the binasal prongs up to 42.5%. So they were changing from nasal mask to nasal prongs to minimize the risk of nasal injury. Still, they reported 42% in their patients, which is about 30 cases per 1,000 days of nasal Cpap. Stage 2 to 3, which is here. So here, a little bit of erythema. And here, you can see a little bit of ulceration and more deep ulceration here. So they found 3.5 cases per 1,000 days of nasal Cpap. So these are very, very concerning to the clinicians as well as to the baby and the parents. Here is another paper from the US where columnar reconstruction following nasal Cpap injury with the prongs. You can see still, even after surgery, this baby's nose is still not normal. So when we started using it in the delivery room, this is one of our smallest babies. We had a discussion yesterday about how small the baby should be. So a 24-week, I run a big fellowship program in our place. We have 18 fellows, so we train them to intubate. And I don't go to the delivery room. I want them to do it. I stay in the NICU. And my fellow went there, and baby ended up as 270 grammer, could not intubate the baby. We didn't have a 2.0 endotracheal tube at that time. Now we have it. But so he decided, okay, I'm going to put the baby on the RAM cannula and resuscitate. And he brought the baby well, resuscitated into the NICU. Baby has umbilical arterial line, umbilical venous line, and now they have to give surfactant to this baby. So I said, okay, go and intubate and give surfactant. He said, no, I couldn't do it, so you better do it. So we intubated the baby with 2.5, gave surf, and I said, okay, I'm going. No, we have to extubate this baby. So we extubated the baby back to NIPPV cannula. This baby is now over 12 years old. I see this baby every year during Christmas time. So we were very delighted that we are able to support this baby, even as small as 270 grams. That's in my 36 years at the USC, first baby to survive under 300 grams. So it doesn't happen that often. Oh, I think you guys are playing now. You can see the chest rise, we're able to ventilate the baby, got the blood gases. Baby had mild acidosis and turned out to have sepsis and pneumonia, but we were able to manage the baby. This is what we do routinely now. No matter what the size of the baby is, we start the baby with RAM cannula in the delivery room. We don't keep even mask. Day after the third draw, we have it. We usually have it in June, July, when the new fellows come. They start from different programs. So they're not used to it, even though we do in-service. We keep that in case if they're not. Usually my senior fellows or attendings, we go with the first-year fellows to the high-risk deliveries and bring the baby, do whatever you want to do. The baby is already attached to the ventilator and baby is getting Cpap, NIPPV, and we give surfactant using the insured technique in the beginning. Now we do LISA. Again, just to show that, in this high fidelity new SIM B, the mouth is open, so we have to close the mouth. That's my respiratory therapist demonstrating that you can do Cpap or you can actually see the chest moving. So clearly pressure can be transmitted. And I'll show you some clinical data. So we published this paper in Resuscitation, my colleagues, Dr. Biniwali and Fiona, in 2017. Again, it's an observation retrospective study. We were using Cpap with face mask, and then we started using NIP with RAM nasal cannula. All babies less than 1,500 grams, and you can see mean birth weight is similar, gestation age about 27 weeks. Intubation in the delivery room was much higher, 85% compared to 31%. Emergency intubation was also significantly lower. We were able to effectively resuscitate the babies. Upwards were not different. Need for chest compression was also less, 11% versus 31%, slightly because we are not inducing the TCR reflux and bradycardia. Air leak syndrome, no increase. IVH, no difference. Need for invasive ventilation at 24 hours of age, 38% compared to 66%. Even if babies are intubated, median duration of invasive ventilation is 11 days compared to 2 days when we continue with NIPPV with the nasal cannula. Again, nearly 90% of the babies in both groups got surfactant for the diagnosis of RDS. We did a similar retrospective study from our NICU. These are over 1,500 gram babies. Does it work in bigger babies? The answer is yes, but again, not a randomized control trial, just our observation. And we showed the intubation rate was 15% in the face mask group compared to 7% in the RAM cannula group. And number of babies remain intubated at 24 hours of age, 17% versus 7.6%. Median duration of ventilation with intraquartile range, 1 to 5 days. These are bigger babies, so most of them got extubated. So we can do with any mode of you want to do bubble Cpap? Yes, you can do with bubble Cpap. Some of the things we do is to keep the blue to the sky. The blue is usually the inspiratory tubing, so that any water condensation doesn't get into the baby, especially with high humidity in the delivery, in the incubator. There is a lot of condensation, so we try to use non-heated mode if there is too much condensation in the tubing. We also keep the head end about 20 to 30 degrees, so all the water will come down into the circuit and not into the baby's nostrils. We use it in any mode. We started before we had the jet ventilator. We used oscillation. This is in 2010. This was a baby that came to us from another hospital. He's gone home, and mom unfortunately put the baby in hot water when she was giving back. Baby had a 10% burn. So baby came in, had BPD on top of that, so pulmonary hypertension. So we're able to manage the baby on nasal cannula oscillation, sildenafil, NG tube, Neplex dressing, and we were able to discharge the baby home safely. Never needed intubation. So there are case reports using Brager baby log. This is a study from Turkey that they again reported in 3 cases that nasal high-frequency oscillatory ventilation can be used safely, effectively. These are experience, obviously. So more recently, we published a paper last year in the Journal of Perinatology, because when we started nasal oscillation, the baby was shaking a lot. The nurses said, the baby is shaking too much. I said, okay, they were worried about IVH. We said, let's try jet ventilator. So I called the jet, Dr. Bunnell, the inventor of jet ventilator, and said, could you check and make sure your machine still works, all the alarms? He said, yes. I tested it, and then we started using nasal jet ventilation. So this is our experience with 18 babies, again, a retrospective study. Birth weight 690 grams. Baby's nasal jet does fail. So younger the baby, 500-gram babies fail. Gestation age 24 to 25 weeks. Age when we started nasal jet ventilation is 30 days to 37 days. These are babies that were on NIPPV and they were failing NIPPV. Instead of intubating, we said, let's do nasal jet or nasal ventilation. Again, this is the first reported series to our knowledge of successful use of nasal high-frequency jet ventilation. Currently in the US, there is a randomized controlled trial of 40 preterm babies from Brad Yoder in Salt Lake City, Utah. Again, they're not using the RAM cannula, they're using a regular Inca or Hudson products. So this is what we do now. We start with NIPPV, it fails, approaching the failure rate, then we just fail criteria, blood gas, hypercardia, acidosis, we switch the babies to nasal jet. The question always comes up, how do you know how much pressure you're delivering? Well, when using Inca prongs, Hudson prongs, do you know how much pressure you're delivering? Absolutely not. Zero idea, right? So here, Robert Chapman, who is has done lots of studies in neonatology, is very well known. And Dr. Prabhu Iyer, who is a neonatologist, he was in Cleveland, now he moved to Los Angeles. And they measured the pressures using a validated test lung model, computerized test lung model, called ASL 5000. And they showed that depending on the size of the cannula, preemie, newborn, or infant, the amount of PIP that you dialed in that gets into the hypopharynx is about 75% with the preemie cannula, 80% of the newborn, 85% of the infant. So if you are using in a 600 grammer, a PIP of 20, the baby at the hypopharyngeal level is getting about 13 to 14 centimeters. How much gets into the lung? It's anybody's guess. If the baby keeps the mouth open, you're going to lose pressure. So sometimes we close the mouth. So here is a nice study from Hyderabad, India. Sharma and Murthy, Srinivas Murthy has done lots of studies, respiratory studies. They published this paper in 2020. 90 babies, mean gestationally 31 weeks, mean birth weight 1.3 kilo. They compared Hudson prong versus RAM cannula versus mask. And this is what, 5 centimeters or 6 centimeters. Measured Cpap levels. So they used a water-filled catheter and then measured the pressure. So measured Cpap levels are low in all interfaces. Nasal mask delivered the oropharyngeal pressure best matched to the set Cpap. If you set it at 5, you get 4.5. If you set it at 6, you get 5.5. Look at the difference between RAM cannula and mask is only 0.6 to 0.7 centimeters. So if you're used to using Cpap of 5, I would recommend 6. If you're using 6, I would recommend 7. So the baby will still get what we wanted to do. So again, This is an FDA approved, this Medtronic's Puritan Minute 980 ventilator have a new NAV software, NAV Plus. So they validated all these prongs, RAM cannula, Hudson prongs, Fisher-Paykel, Argyle, Medine nasal prongs. And they show that you can actually see what the pressure is coming out of the RAM cannula at the nasal patient level or on the ventilator. We typically use the ventilator to adjust the pressures, right? PIP, what is, but that's not what the baby gets. So you can actually calibrate before you put the baby on the put the ventilator, attach the ventilator. You can see how much pressure it is. If you have 30% or less leak, you're pretty much getting very close. You can actually manage the babies based on the reading here at the interface rather than on the ventilator. And another ventilator that we used before for the closed loop study, Avia ventilator also has been validated and the FDA approved when we did the study. So here is another randomized control. So people ask, okay, are there any randomized control trials? And I am maybe so biased in my unit. If I bring in nasal prongs, my unit will say, why are you doing this? You have good success, right? So I said, let somebody do it. I'm glad from Israel, the study was published in JAMA Pediatrics in 2020. They did a randomized control trial on babies between 24 to 33 weeks comparing RAM nasal cannula with binasal prong. Birth weight, about 900 grams. Intubation within 72 hours after they were randomized to either mask or cannula, 14% versus 18%, no difference, equal. Maximum PIP, PEEP, and respiratory rate, they used 19/6, a rate of 30. In the binasal prong, 18/6, rate of 25. And I'll show you what we do. BPD rate was not different, neck was not different, time to full feeds, another thing that people ask about. Anytime you put a baby on NIPPV or even nasal Cpap, you're going to get what is known as Cpap belly. So you have to aspirate this with a NG2. Moderate to severe nasal injury, 5% of the RAM cannula compared to 17%, moderate to severe nasal injury. So they concluded that in this study, they called it CLINT, RAM cannula, was non-inferior to short binasal prongs, providing NIPP for preterm babies while significantly causing less nasal trauma. The second randomized control trial just published in December of this year, last year, 2021. Again, they did a randomized control trial, 28 to 34 weeks, 229 babies. And the conclusion was preterm babies on nasal Cpap, RAM cannula with cannulite, they used cannulite to protect the nose, compared to Hudson prongs, decreases nasal injury without increasing the need for mechanical ventilation. 5.4% nasal injury compared to 26.4% with the prongs. Again, if you look at the Cpap versus NIPPV, 10 randomized controls have been published, either as a primary mode or following a period of mechanical ventilation. In 1999, and then Keith Barrington from San Diego, Kalaf from Philadelphia, Google from Israel, Morati from Rome, Kishore from India, Lista from Milan, Menzies from South America. Again, in 2012, we did a multi-center trial of Cpap versus NIPPV, and we used the RAM cannula in the 2012 study. And we can see that if you have NIPPV post-extubation or primary mode of support, you clearly decrease the need for re-intubation. How do we use it? So baseline pressure P, as I said, we start at 6. If the lung is not well expanded, FiO2 is high, we go to 7. PIP, we start at 20. Big, medium, small, it doesn't matter. We start at 20/6, rate of 40. Inspiratory time 0.5 seconds. We tried 0.8 and 1 second. It didn't make any difference. We stayed with 0.5 seconds. And duration of high pressure, inspiratory time, at least 4 to 5 times the time constant, because any nasal interface, you're going to have longer time constant, that the resistance is higher, right? You have to use long inspiratory time. Don't use 0.3, 0.4, it doesn't work. At least 0.5. In BPD babies, after 2 or 3 weeks, baby has lung disease, airway disease, we have to use much higher pressures. We use as high as 30 to 38 peak inspiratory pressure. Peak of 6 to 10, occasionally we do even 12. So if you're worried about using higher pressure, don't use NIPP, it will fail. That's exactly what Harish Kirpalani showed in his trial on NIPP versus nasal Cpap. We have to use higher pressure. Nowadays, if you go to even a chronic baby, if I have to use 30 or above, I just go to nasal check. We are able to ventilate them very easily. Or nasal oscillation you can do with trach. So again, how do we wean? When the FiO2 is less than 40%, 0.4, PCO2 is less than 60 or 65, pH is over 7.25, we wean the PAP first. I really don't want the nasopharynx to be exposed to high pressure. Physiologically, not supposed to be. So I always wean the pressure first. Once I'm down on the PIP to 12 or 15, then I start weaning the rate and the FiO2. And the rate is down to 12, FiO2 is less than 0.3. We switch the baby to nasal Cpap. 24 hours, baby's doing well, no apnea, no desaturations. Then I switch the baby to low flow cannula. Again, as I'm weaning the rate to 20, baby has more apnea, bradycardia, I just go back to the previous rate, 25 or 30, wait for another 12 or 24 hours, and then start weaning. Hypercapnia, no. Okay. So wean PIP first, hold the rate. I always tell my group, when do you want to wean the rate? I say after the baby goes to school. So there's really no reason to rapidly wean the rate on this baby. They have hypopnea or shallow respirations. That is what causes desaturations, apnea, bradycardia. So leave the rate, number one. Number two, having a higher rate actually causes respiratory unloading. A study from Miami, Bangalari's group showed that respiratory unloading is much more, that is better at higher rate. So every time baby has shallow respiration, the NIPP breath supports the baby. Therefore, baby can use the energy to grow rather than spend on breathing. Once the baby is stable, PIP is low, we wean the rate. These changes we make every 6 to 12 hours. And we try not to make too many changes. And then baby does not tolerate weaning, just go back to the previous setting, give another 12 to 24 hours. Again, if somebody wants to know how much tidal volume we're delivering, you can actually put a flow sensor on the Neonatal and measure tidal volume going in through the cannula. Again, fixing. This baby says, my cannula is fixed well, don't touch me. Again, most important thing is to give a gap between the columella and the nasal cannula interface. That's the best way to avoid nasal injury. Again, stay away from the nose columella, make nose rounds, just like Dr. Ali said about ET tube and mask rounds. Every time somebody walks by, I say, make sure the cannula prongs are in. Sometimes it's off, the ventilator will be cycling. The same thing with bubble Cpap. It will be bubbling, but the prongs may be out, right? So you have to make sure it comes. We use the white tape, and we're able to fix it very well in this even small babies. Anytime you see even a slight redness like that, if they showed in Swiss study, we make sure that it's not touching. Use the septal guard, we have to. When fixing the nasal cannula, make sure there is a gap. We sometimes use a pacifier if you are having trouble ventilating the baby to minimize the beats. What about the high flow nasal cannula? People ask me, can I use RAM cannula as a high flow nasal cannula? Today, there are no randomized control trials that shows high flow nasal cannula as a primary support or following a period of invasive ventilation results in better outcomes. In fact, we have higher failure rates. So I do not recommend using RAM cannula as a high flow nasal cannula with flow rates greater than 2 liters per minute. Thank you so much for your attention.